Ma'am, you are live now.
Okay. Hi everyone. Good afternoon. I hope I'm audible and visible to all of you. If I'm audible and visible, give me a quick thumbs up so that we can begin the session. Is everything all right? Okay, so I think I've gotten the confirmation. So today we are going to discuss some of the PYQs. So what I'm going to offer today to all of you is going to be 2025, the last examination, all the questions we're going to discuss in detail because that's the latest exam that we have in hand and the question paper is the latest. So we're going to focus on that. And then we are going to have the next discussion on the last 5 years, which is from 2020 to 2024 questions. And the questions which have been repeated, like for example, there are questions on JNA, there are questions on NPC, there is question on CSOM, there is question on SOM, there is question on for example, laryngeal cancer. So in those areas where we have repeated questions coming, I have given that question only once. I have not repeated it again and again. So certain topics which have been an overlap across all the years, I've just reduced them down to one question, and then so that we can cover most of the things in a short time. So this is essentially going to be a very quick session, maybe 1.5 hour maximum. We have about 40 questions to discuss. About for most of them are going to be 2025 in the beginning, and after that we continue forward. Okay. So hello everyone, and I can see that there are many hellos here, so I'm very happy to see all of you. Right, so are you all ready to start the 2025 recall? If yes, quickly give me a confirmation in the chat box. Let's take a thumbs up and then start the session. Okay, so we have a question here which says that a tuning fork test was done which shows that the Rinne is negative on the left side and positive on the right side. Okay, so Rinne is negative on the left, positive on the right, and Weber lateralizes to the left side. So what are they telling? Let's write down this. What are they telling to you? Rinne is negative on the left side, positive on the right side. Weber is going to the left side. Audiometry is showing to you that on the right side there is a slightly flat threshold around 20 to 30 decibels, which means that AC and BC are somewhere between your 20 to 30. But in the left ear, there is a deeper threshold, which means that in the left ear, BC is in the normal range, AC is in the abnormal range. What is the most appropriate diagnosis? So if you have BC normal, AC abnormal, and you have got an airborne gap between the two, and you see that the Rinne is negative on the left side and Weber is going towards the same side, and you get a AB gap on the left ear, what is your diagnosis? Is it right conductive loss, left conductive loss? Is it right sensory neural hearing loss or left sensory neural hearing loss? What do you think is the answer? Quickly tell me in the chat box, what do you think is the answer? Yes, very good. The answer is left conductive hearing loss, because we know that whenever the Rinne is negative on the one side and Weber is lateralizing towards that side, then we say that it is left conductive hearing loss. Now let's say if the Weber was going to the right, then what would your answer be? So let's say this is the combination that would have been given to you in the exam, then what would your answer be? If the Rinne is negative on the left, Weber is to the left side, what is the diagnosis? We know now. But if they would have given you a different diagnosis here, like for example, negative on the left, Weber is not going on the same side, opposite side, then then what would your diagnosis be? Where do you get a false negative Rene? This is not true negative, this is a false negative Rene. Because if it was truly negative, the Rene would have gone to the same side. But if it is, the Weber would have gone to the same side. But if the Weber is not lateralizing towards the same side, it is going to the opposite side, then it is a false negative Rene which is seen in unilateral, and in this case it is going to be left-sided, severe to profound SNHL. So unilateral, severe to profound SNHL, you are going to get a false negative Rene. Now let's see what is the diagnosis here. Left, let's say the Weber is going towards the right side, Rene is positive on both the sides. What will your diagnosis be? Quickly, guys, we've seen a lot of questions coming from the tuning fork test, a lot of questions coming from audiometry. So this is something we cannot skip. So quickly tell me the answer. Yes, very good. In this situation, because the Rene is positive, essentially it could be normal or SNHL. But if the Weber is going to the right side, it means that the patient is having left sensory neural hearing loss. Because whenever we say Rene positive, it means there are two differential diagnoses, either normal or SNHL. In normal, the Weber will lateralize towards the same side. In SNHL, it will go towards the opposite side. If Rene is negative, then we think of conductive hearing loss. And in conductive hearing loss, it is going towards the same side. I mean, here normal means it is heard in the center. Okay, this is how we will take the inference. I hope everyone is clear about this. If yes, quickly give me a thumbs up so that we can go to the next question. Our question was talking about this situation where the Rene is negative on the left, Weber is going to the left side, which is seen in conductive hearing loss. Okay, a 45-year-old man with presents to you with abnormal gait and hearing problem and is found to have a cerebellopontine angle mass. Histopathology is showing to you typically Antony type A and Antony type B with verrucoid bodies. What is the most likely diagnosis? Whenever you see Antony type A, type B, verrucoid bodies, what is the likely diagnosis? Is it a schwannoma, oligodendroglioma, glioblastoma, or medulloblastoma? What do you think is the diagnosis? Yes, we know that this is a very typical history of acoustic neuroma, also called as vestibular schwannoma. Acoustic neuroma or vestibular schwannoma is a benign tumor. It is a locally invasive tumor, originates from the vestibular nerve. It presents to you with, of course, unsteadiness. It presents to you with abnormal gait, and because there is compression of the eighth nerve, they present to you with SNHL, and there is going to be poor speech discrimination. This is the buzzword whenever they are going to use for acoustic neuroma, that there is a poor speech discrimination. This is something that is going to tell you that it is acoustic neuroma on history. Now, of course, you are going to do audiometry. Audiometry, the red flag is going to be unilateral SNHL. So, if you get a unilateral SNHL with poor speech discrimination, these are your key diagnostic features that are going to tell you that it is cerebellopontine angle mass. Now, if I ask you what is the audiometric investigation of choice, what will your answer be? It's going to be BERA. On BERA, what will you see? You will see that there is loss of wave 5, that tells you that it is acoustic neuroma. Now, if I ask you what is the general investigation of choice, then the general investigation of choice is MRI with contrast. MRI with contrast will show you that there is an ice cream cone appearance, and this ice cream cone appearance is seen very, very specifically only in acoustic neuroma. Now, when the tumor is less than 3 centimeters, you do a single large dose of radiation, which we call it as radiosurgery. And if it is more than 3 centimeters, we go for surgical excision. So I think we've covered all the important points of acoustic neuroma here. Let's go to the next question. A boy sustains a nasal bone fracture, which is seen on a lateral x-ray. The forceps that is used for closed reduction of nasal bone fracture, which forceps do you use? Do you use a Tilly's forceps? Do you use a Walsham's forceps? Do you use a Lux forceps? Or do you use a bayonet forceps? Yes. So we know that whenever there is a fracture for nasal bone or the septum, we have some specific forceps. If you see that there is a forceps which has a bend, which has an angle, angulated forceps, A for A, remember it is for Ashes forceps. This Ashes forceps is used for septal fracture reduction. Whereas if you see a flat, a non-angulated one, a non-angulated forceps is called as Walsham's forceps, and this Walsham's forceps is used for nasal bone reduction. So whenever there is a fracture of the nose, whenever you want to do a closed reduction, what is the optimal time when you do the closed reduction? Closed reduction is done somewhere between 5th day to 7th day, maximum till 10th day, because that is the time when edema will decrease, allowing you to do a good reduction. And the second of all, there is no union that is complete. If you go beyond 10 days, there is already callus, the union has begun, so it is going to be difficult to distract the bone and do it again. So ideal time is somewhere between 5th to 7th day, maximum you can do it up till 10th day. Okay, so that is about it. What are the other forceps that we have? Tilly's forceps is used for nasal packing. Whenever we want to do nasal packing for epistaxis, then we are going to use the Tilly's forceps. Lux forceps is used for many purposes. Mainly it is used for tonsil surgery. It is also used for septal surgeries. Bayonet forceps can be again used for packing, nasal packing. I think that is understood. Which of the following statements regarding orbital cellulitis is true? Inflammation is restricted anterior to the orbital septum. Ethmoid sinus is the most common source of infection. Topical broad spectrum antibiotics are the first line of management. And first presents to you with proptosis, blurred vision, and there is going to be normal extraocular movements. What do you think is the true statement for orbital cellulitis? Let's go one by one. Is the inflammation anterior to the orbital septum? No, this statement is false, because if there is inflammation anterior to the orbital septum, we call it as preseptal cellulitis. So what do we call it as? Preseptal cellulitis. It is not called as orbital cellulitis, so this statement is false. Let's go to the second one. Regarding orbital cellulitis, is ethmoid sinus most common source of infection? Yes, whenever we think of orbital cellulitis, ethmoid is the most common source of infection, whether it is young or whether it is old. This is a true statement. Do you want to give topical antibiotics or do you want to give systemic antibiotics? So systemic antibiotics are given, so this is a false statement. Patient presents to you with blurred vision but normal pupillary reflex. This is false. The pupillary reflex extraocular movements are going to be abnormal. So I think we now know the true statement, which is ethmoidal sinus is the most common source of infection. Now this is a standard question that you see many times. A male child in the second decade has recurrent profuse bleeding of the right nasal cavity. So whenever you hear the word male, if you see bleeding, if you see young age, what is your diagnosis? There is a mass that is occupying the posterior choana. What is the diagnosis? So mass in the posterior part of nose. Yes. Do you think is it an antrochoinal polyp, angiofibroma, or is it a rhinoscleroma or rhinosporidiosis? Yes, these are the buzzwords for your angiofibroma. Again, angiofibroma is going to be your benign tumor and it is going to be your locally invasive tumor. This benign tumor is known to originate most commonly from which foramen? Spinopalatine foramen. Spinopalatine foramen is located 1 centimeter behind the middle turbinate near the posterior wall of maxillary sinus. Okay, so it's located near the posterior wall of maxillary sinus. Presentation is into three groups. Either it can present to you with bleeding, obstruction, or cranial nerve palsies. In obstruction, we can see that there is going to be a deformity, which we call it as frog face deformity and unilateral SOM. In cranial nerve palsy, it is the second, third, fourth, fifth, and sixth cranial nerves that are involved, and I'm sure all of you know this. Now, the investigation of choice is going to be contrast enhanced CT scan, where we see there are three signs. What are the three signs? There is going to be Hallman-Miller sign, there is going to be Hondusa sign, and there is going to be another sign where you see that the pterygoid is eroded and there is a chopstick like appearance of the pterygoid plates, that we call it as chopstick sign. Now you will also do angiography to identify the feeding vessel, and the most common feeder is going to be your internal maxillary artery. Once you have identified the feeder, then you are going to embolize it. So what is the treatment? Treatment is embolization followed by surgical excision. Okay, so I think this is sorted. Everyone has understood JNA. Let's go to the next question. A patient presents to you with odynophagia and lymphadenopathy. So there is painful swallowing and there is cervical lymphadenopathy. There is a growth on the base of tongue confirmed as squamous cell carcinoma. Which organism is associated with the cancer? Is it HPV? Is it EBV? Is it CMV? Or is it HSV? Which virus is associated with a tongue base cancer? So whenever we think about tongue-based cancer, you should think, where is the tongue base? Is it lying in the oral cavity or oropharynx? Yes, it is lying in the oropharynx. So whenever we think of oropharyngeal cancers, there are two viruses that are predominantly involved. It is not CMV or HSV, it is HPV or EBV that are commonly involved. Now, when we think of tonsillar malignancies or adenoid malignancies, nasopharyngeal malignancies, then EBV will be something that we will consider. But when we think about tongue-based cancers, then it is going to be HPV. Typically, your HPV 16 and 18 strains are typically involved, and hence your answer is going to be HPV 16 and 18. This is the closest differential, but your answer in tongue-based malignancy will be your HPV 16 and 18. Okay, so I think that is also sorted. Now we have the next question. For a patient has a fall from the building and is brought to you with copious debris in the mouth, making it difficult to intubate. An emergency surgical procedure is performed in the neck. Which statement is true? It provides effective ventilation for 6 hours. It should be followed by a formal tracheostomy. It measures the central venous pressure. Work of breathing is normal through it is less than with bag and mask ventilation. So in a patient who cannot be intubated, yes, cannot resuscitate, cannot intubate, or cannot oxygenate. In this patient, what will you do? You will do an emergency cricothyrotomy. So when you're doing an emergency cricothyrotomy, you're going to open the cricothyroid membrane. When you open the cricothyroid membrane, can you last the ventilation for 6 hours? No, it is false, because we cannot keep the patient ventilating for 6 hours, maximum for 1 to 2 hours. That is maximum. So we cannot provide effective ventilation for 6 hours. So this statement is false. Then second one, if can we do central venous pressure measurement through your cricothyrotomy? No. It should be followed by a formal tracheostomy. Yes, because you cannot keep a patient on cricothyrotomy for a long time. So you have to do a tracheostomy, and work of breathing is of course not less. It is more than bag and mask ventilation. So the correct statement is option C. A 55-year-old patient presents to you with hoarseness of voice, difficulty in swallowing, and difficulty in breathing after being diagnosed as a laryngeal cancer. Surgical management is performed, and we are seeing that there is a single round stroma in the lower part of the neck where the trachea is sutured directly to the skin. What surgery is done? So, in which condition will you do a permanent tracheostomy where the trachea is sutured to the skin? In which condition will you do a permanent tracheostomy where the trachea is sutured directly to the skin? Yes, you will do it after total laryngectomy, because if the larynx is not there, you have cut the larynx with the first tracheal ring, you bring out the rest of the trachea outside for breathing. So we do this permanent tracheostomy only after total laryngectomy. It is not a standard tracheostomy. Why is it not a standard tracheostomy? Let me explain this to you. So let's say this is your larynx, and this larynx continues down as trachea, right? So whenever we are doing a tracheostomy, which is a standard tracheostomy, we make an opening between the second ring and third ring, or third ring and fourth ring. But now when we are doing a laryngectomy followed by tracheostomy, we cut the larynx along with the first tracheal ring, and we bring out the rest of the trachea as a permanent tracheostome. So are we going higher to do a tracheostomy? So in patients with laryngeal cancer, we will do a high tracheostomy, not a standard tracheostomy. Standard tracheostomy is at the level of second and third tracheal trach. Yes. A 3-year-old child is brought to the casualty after choking on a peanut and suddenly becomes unresponsive. What is the next management? So the child is becoming unresponsive. Will you give back slaps? Will you give abdominal thrusts? Will you perform endotracheal intubation, or will you do chest compression and CPR? See, the child is unresponsive. If the child is responsive, your answer would have been to give back slaps, and then you would have tried to do the Heimlich's maneuver also, where you would make the child to lie down in the back and then you give back slaps. That is what we can do. But if it is the child responsive and the child is unresponsive and the child has choked on a peanut, the next thing is to do a CPR. And what do you do in CPR? Start off with chest compression. So this word is very important, which will change your answer. A patient had negative Rene's test on the left ear and Weber is lateralizing towards the left side. Otoscopy shows central perforation of the tympanic membrane. What type of hearing loss is this? So this question has been repeated in 2025, 2024, also in 2022. They have given this question in multiple formats. Once they have given as a tuning fork test finding and asked you the diagnosis. Once they have given you an image based question like this and asked you the diagnosis. So you should be able to answer. Rohan, backslaps are done only if the child is responsive. Second of all, there is a variant of Heimlich's maneuver which we do in adults versus children. So if the child is less than 3 years of age or less than 1 year of age, we make the child lie down and the prone position over the forearm and the hand like this, and we give backslaps. If the child is about 3 to 5 years of age, we put him on the thigh of the examiner and we give backslaps. So there are different variations of Heimlich's, but we can do Heimlich's only if the child is responsive. Because the question is unresponsive, our answer is changing towards CPR. Okay, so I think this is very easy. Whenever there is a perforation of the tympanic membrane, what you see here is a subtotal perforation. A subtotal perforation of the tympanic membrane indicates to you that there is a conductive pathology. Conductive pathology in the left ear will cause a left-sided conductive hearing loss. Okay, so they have given you also the Rene's test being negative, Weber going to the left side, otoscopy examination is here. So we now know the answer is left-sided conductive hearing loss. So Ram, whenever we say Rene positive, either the patient is normal or having SNHL. Whenever we say Rene negative, the patient has a conductive hearing loss. Whenever we look at Weber, if there is equal distribution or heard in the center, if I put a tuning fork here, it is heard in the center with equal distribution, then that's normal. If it gets lateralized towards one ear, if it goes to the deceased ear, it is conductive hearing loss. And if it goes to the opposite ear, then it is sensory neural hearing loss. Okay, so I think this is also understood. Shoaib, I will explain to you laryngeal palsy when the question comes. Okay. A young adult has a perforation of the tympanic membrane. Again, a 24 question. Otoscopy shows to you recurrent ear discharge. What is the most appropriate definitive treatment? Topical eardrops alone, tympanoplasty, mastoidectomy, hearing aid without surgery. Yes. So if you see here, this is a dry perforation. So if they have given to you a perforation and there is no active discharge, this is a dry central perforation which can be seen in a mucosal type of otitis media. So if we see CSOM, it can be mucosal type or also called as tubotympanic type, or it could be a squamosal type, which we call it as the atticoantral type. Right. So if there is a tubotympanic type of a disease or mucosal type, you should see is there any discharge or there is no discharge. If there is any active discharge, we call it as an active mucosal. So in an active mucosal, the first step will be to make ear dry. In that you will give topical antibiotics, you will give systemic antibiotics, and after doing all that you will go for further treatment. But if it is a patient who has discharge, the patient is presenting to you with an active discharge, because this came in the INI 2026 exam where they showed that the perforation had active pus coming out of it. Then what will you do? If that is with pus, then you are going to do an active disease, the treatment protocol. But if it is without discharge, then what are we going to do? Which was asked in 24 NEET PG examination. Here we are going to go directly to surgery. We have to do, of course, investigations prior to understand why it has happened. We'll do a CT scan of the temporal bone, but that is not given in your question. So your answer will be to do a tympanoplasty, repair the tympanic membrane. If they would have given to you myringoplasty, even that would still be the right answer. But if they would have given you middle ear disease plus mastoid disease seen on X-ray or CT scan, so X-ray or CT is showing to you mastoid disease, then what will you do? Then what will your answer be? Then you have to do tympanoplasty for repairing the middle ear plus mastoidectomy to clear the disease from the mastoid. And that is not mentioned here. That is why we are not taking mastoidectomy. Hearing aid alone will in fact aggravate the disease because air won't go and it will aggravate the CSOM. Topical antibiotics alone will not close the perforation. It is only to make the ear dry in an active disease. Yes. Let's go to the next question. An elderly smoker presents to you with dysphagia and is diagnosed with a large advanced squamous cell cancer. What surgical procedure is the most appropriate one? So there is a large advanced squamous cell carcinoma. So if you see, laryngeal cancer is a hot topic that you see in any exam. You should know everything about laryngeal cancer. So first of all, let's see the staging of laryngeal cancer. We have stage 1, stage 2, stage 3, 4A, 4B and 4C. What is stage 1? It is T1, N0, M0. What is stage 2? T2, N0, M0. What is stage 3? It could be T3, N0, M0 or T1, T2, T3, N0 becomes N1. So if a disease is N1, then we call it as stage 3. What is stage 4A? It could be T4A, N0, M0 or it could be any T between 1, 2, 3, 4A. But now N1 becomes N2, M0. Then we call it as stage 4A. And what will be 4B? It will be T4B, N0, M0 or any T1, 2, 3, 4A, 4B. N2 becomes N3, M0. Then we call it as 4C. And if it is any T, any N but M1, then we call it as 4C. So I think the staging is clear. Whenever it is N1, we mark it as stage 3. When it is N2, we mark it as 4A. If it is N3, we mark it as 4B. And if it is any T, any N but M1, then it becomes 4C. Stage 1 and stage 2, very simple. The same T1 becomes T1 N0 M0, stage 2 becomes T2 N0 M0. So this is only thing that you should know about the staging. Okay, now let us go to understanding what is T staging and N staging. I am discussing this in a little bit of detail because we are seeing a lot of questions. T1 is if it is involving one subsite of the larynx. So from the larynx, only one subsite is involved. We call it as T1. Here the vocal cords are completely mobile. What is T2? More than one subsite of the larynx is involved. Like from supraglottis, it's going to glottis. Glottis, it's going to subglottis. And here the vocal cord is partially mobile. Then you call it as T2. What is T3? Here definitely more than one subsite is involved. But here three things happen. Either the vocal cord is fixed. Then there is involvement of spaces of the larynx, or there is involvement of inner perichondrium of the cartilage. So which perichondrium? Inner perichondrium is involved. What is T4A? If there is a local spread, we call it as T4A. And if there is a distant spread, we call it as T4B. Okay. So this is your T classification. What is N classification? N0 is there is no neck node. N1 is less than 3 centimeters. N2 is if the size of node is between 3 to 6 centimeters and N3 is more than 6 centimeters. In N2, you have 2A, 2B and 2C. If it is single node and on the same side of the primary cancer, which we call it as ipsilateral, we call it as 2A. If there are multiple nodes and ipsilateral nodes, then we call it as 2B. And if there are contralateral nodes, then we call it as 2C. So 2A is single ipsilateral, 2B is multiple ipsilateral, 2C is contralateral. So this is how we are going to do this staging. T classification, N classification and M classification, where M0 is no metastasis and M1 there is distant metastasis. So with that, now we know what is the staging T, N, M. Now let us see the treatment. If a patient comes to you as a primary patient, a first timer patient, and this patient is in stage 1 or stage 2, your answer will be radiation therapy. There is only one exception to this rule. What is that one exception? If there is a carcinoma of middle 1/3 of vocal cord, what will you do? You will do a microlaryngeal surgery. Now, if a patient presents to you with stage 3 and early 4A disease, then what will you do? Then you are going to give chemo-RT. Again, there is an exception here. The exception is if there is carcinoma of the epiglottis going to the pre-epiglottic space. In this situation, we will do a partial laryngectomy, not chemo-RT. Now, if there is a patient who has advanced malignancy, then we are going to go for total laryngectomy. If one arytenoid is spared in the disease where it's advanced and one arytenoid is spared, both the arytenoids are not involved, one is spared, then we do near total, otherwise we do total. So just for now, take it as total. Now, if a patient comes to you with recurrence and the patient is in stage 1 or stage 2 in recurrence, what will you do? You are going to do a partial laryngectomy. And if the patient is in stage 3 or more, then you are going to go for total laryngectomy. Now, if a patient cannot take chemo-RT, so if a patient cannot take chemo-RT, then what will you do? Then again you will do a total laryngectomy. So I hope is the treatment understood. Primary patient, first time stage 1, stage 2 RT, stage 3, stage 4A early lesions, chemo-RT. Advanced malignancies, total laryngectomy, only one exception if one arytenoid is spared, near total. Stage 3 and stage 1, stage 2 in recurrence, partial laryngectomy, 3 or more, total laryngectomy. So now with this, answer the question here. They have told you advanced laryngeal cancer, what surgical procedure is most appropriate? Is it partial laryngectomy, total laryngectomy, cricothyroidotomy or tracheostomy? See, there is no RT given, chemo-RT given, advanced laryngeal cancer. So what will you do? You have to go for a total laryngectomy. Okay, so you have to answer total laryngectomy. Even if they would have given you 3 or 4A early lesions, we would think of chemo-RT, but that option only is not there. So your answer becomes total laryngectomy. So I think this is sorted. Let's go to the next one. A patient, young male, has recurrent bleeding from the right nasal cavity that fails to stop with anterior nasal packing. Which is the most appropriate to ligate to control the bleed? Facial artery, sphenopalatine artery, superficial temporal artery or the lingual artery? Yes, very good. So whenever we talk about epistaxis, there is a protocol for management of epistaxis. The first step is called as Trotter's method. What is Trotter's method? Pitch the nose and bend forward. We call that as Trotter's method. After that, you will do a initial medical review and you are going to do a resuscitation for the patient. So initial medical review and you're going to do resuscitation. After that, you will do a nasal endoscopy. If on nasal endoscopy you see a single bleeding point, what will you do? You are going to cauterize it. If you see that there are multiple bleeders, then you will do anterior nasal packing. If anterior nasal packing fails, then what will you do? Posterior nasal packing, which is not given in your options. If posterior nasal packing fails, then you'll do ligation of artery where sphenopalatine artery is first ligated, then internal maxillary artery, then you have got the external carotid artery and the ethmoidal artery that is going to be ligated. So they have told anterior nasal packing has failed. So ideally we should be doing posterior nasal packing, but the question is asking which artery you want to ligate. You will ligate the sphenopalatine artery, which is also called as artery of epistaxis. Okay? Okay. Next one. A young woman with progressive, so this is also a very easy question. Woman, progressive conductive hearing loss, positive family history, no history of ear discharge, tympanic membrane is normal. What is the most likely diagnosis? So if you guys see, the questions in NEET PG for ENT are coming from very common topics. CSOM, otosclerosis, GNA, laryngeal cancer, and they're always using the similar kind of buzzwords. Only the options vary or the testing pattern will vary. So if you're thorough with these topics, it's very easy for you to answer. Yes. So whenever we think of females who are between 20 to 40 years with a genetic history or a family history where there is an autosomal dominant type of inheritance, where they present to you with bilateral, gradually progressive conductive hearing loss, and they present to you with a particular phenomenon which is called as para-acusis wilsi, where you see that patient hear better in the noisy environment as compared to silent environment, and then you do tuning fork test which will show you that Rinne is negative, Weber lateralized towards the deceased ear. You don't need to do the absolute bone conduction test because it's a conductive pathology, and then you do a audiometry. Audiometry will typically show you a Carhart's notch. What is Carhart's notch? It is a dip at 2000 hertz in which curve? In your BC curve. So a dip at 2000 hertz in your bone conduction curve, we call it as Carhart's notch. And if this is there, we know that our diagnosis is otosclerosis. Very good. So the diagnosis is otosclerosis. So what do we do for otosclerosis? There are three forms of treatment. One, we can give hearing aid to improve the hearing. Patient doesn't want hearing aid if there is an active focus. How do I know there is an active focus? Because if I see the tympanic membrane and if I see that there is a flamingo pink appearance, I will call that as Schwartz sign. So if Schwartz sign is positive, I know that it's an active focus. In this case, I can give sodium fluoride, that too for short term. What is the surgical treatment of choice? Stepidotomy with placement of prosthesis. So we'll do stepidotomy with prosthesis. That will be the treatment of choice. Okay. So that is about your otosclerosis. Most important points have been discussed. CSOM will present to you with conductive hearing loss, but tympanic membrane will have a permanent perforation. Otitis externa is an external ear disease presenting to you with again ear discharge. Presbyacusis presents to you with SNHL, not conductive hearing loss. Okay. So here comes your next question. A patient presented to you with complaints of nasal obstruction and there is greenish crust in the nasal cavity. There is also merciful anosmia. So you can see there is greenish crust. There is merciful anosmia. What finding can you expect in this patient? What are we talking about? Typically, this is seen in females. Again, it is secondary to vitamin A, vitamin D, or vitamin E deficiencies. It is seen with a gram-negative infection, which is also called as Klebsiella oziana. What are we talking about? We are talking about atrophic rhinitis. So what are we talking about? Atrophic rhinitis. Now in atrophic rhinitis, there is atrophy of the nasal mucosa, sinus mucosa, olfactory epithelium. As a result, there will be roomy nasal cavity. There will be a wide nose, but the patient will still feel nasal obstruction, which is paradoxical. They have a condition called as merciful anosmia, where patient themselves are not aware of the foul smell, but the people around them complain of the foul smell. So the answer is going to be roomy nose. What do we do in the treatment? We can give alkaline nasal douching solution. What does alkaline nasal douching solution consists of? It consists of sodium chloride, sodium bicarbonate, and sodium biborate, which is mixed in 280 ml of water, and then that is asked to be flushed. We can give chemicetin anti-oceana solution. We can give estradiol extract. We can give placental extracts. All of that becomes a treatment of your atrophic rhinitis. Now, what is the surgical management? If this fails, then we can do complete closure of the nasal cavity, which we call it as Young's operation. And if you leave a little space to open and allow breathing, we call it as modified Young's operation. And medialization, if you medialize the lateral wall of the nose, we call it as Lawton-Slager's operation. Yes, so this is all that you needed to know about atrophic rhinitis. So I'm trying to finish all the important points and important topics in one page so that it becomes quick summary for all of you. A patient with CSOM presented to you with headache, vomiting, neurological deficits. CT image is given below. What is the diagnosis? So look at this and tell me what is the diagnosis. You can see here there is a ring sign, central hypodense area surrounded by a white ring. We see this only in a brain abscess. So if there is CSOM, if the disease breaks the tegmen, it can go to the temporal lobe of the brain, and if it involves the temporal lobe of the brain, it is going to cause a temporal lobe abscess, also called as your brain abscess. So the answer is option C. Now, if the same thing would have been given to you here, if there was a central hypodense area surrounded by a ring here, then what would your answer be? It is going from the petrous part of your temporal bone. What do you think is the answer? The infection is going from here to the petrous part of the temporal bone and from there to the next. What is the abscess? If the same thing would have been given to you in this way, where the image is showing to you not a temporal lobe but a cerebellar abscess, is that possible? Yes, it goes via the petrous part of the temporal bone. No, Bhuvana, it is not the Bezold's abscess, it is in the sternocleidomastoid. We are in the brain. Look at this leaf-like bone that you have here. This is your petrous part of the temporal bone, medial to which we have the brainstem covered with cerebellum. So the infection can go like this, breaking the roof and cause a temporal lobe abscess. It can break the petrous apex, and from there it can go to the cerebellum to cause a cerebellar abscess. Okay, I hope this is understood now. Let's do the next question. A patient presented to you with epistaxis, not cutting controlled with conservative methods. So I have told you epistaxis is a constant question. So not getting controlled with conservative methods, what is the next step of management? IMAX ligation, ECA ligation, ICA ligation, or endoscopic sphenopalatine artery ligation? Yes, so anterior nasal packing has failed, posterior nasal packing has failed. So what will you do? We've already discussed, you don't jump the gun and go directly to external carotid. You will do sphenopalatine artery. If it fails, then you're going to go for your internal maxillary artery followed by external carotid artery. Okay. Post-thyroidectomy, the anesthetist observed recurrent cyanotic spells while extubation. Why is this? Is this because of bilateral RLN injury, bilateral SLN injury, edema, or hemorrhage? So you should know stridor is a feature of which nerve injury? Yes. So stridor is a feature of bilateral recurrent laryngeal nerve injury. So normally our vocal cords are in which position? Normally the vocal cords are in intermediate position or cadaveric position. What is the meaning of intermediate position or cadaveric position? It lies about 3.5 mm away from the midline. We call it as intermediate position, also called as cadaveric position. Why is the vocal cord in this 3.5 mm away from the midline? Because RLN, which supplies your posterior cricoarytenoid, which is the only abductor, tries to pull the vocal cord away from the midline. Your SLN, which is the secondary adductor of the vocal cord, and the tensor is going to pull the vocal cord towards the midline. So what is happening? SLN is pulling the vocal cord towards the midline and it is tensing it. Okay. So now if we have RLN injured, recurrent laryngeal nerve injured, where is the vocal cord going to come? it will come to midline position. So if both the vocal cords are in midline and both RLN are not functioning because of RLN injury, can the vocal cords abduct during respiration? No. And as a result, will there be stridor? Yes. So stridor is a feature of bilateral RLN palsy. Now, what will happen if there is a SLN palsy, superior laryngeal nerve, if it is paralyzed, you will see that the vocal cord will now go to abducted position. So, if there is a unilateral SLN palsy, the paralyzed cord is in abducted position and it is floppy. The normal cord is in intermediate position. So during phonation, paralyzed cord cannot come to midline, it cannot stretch. The respiration, it is already in the abducted position. So what will happen here in unilateral SLN palsy, they will have a weak voice, a breathy voice. And this position where we see that one cord is in the abducted position, normal cord is in the intermediate position, we call this as askew-shaped larynx. What do we call it as? Askew-shaped larynx. Now if there is a bilateral SLN palsy, both the vocal cords will be in the abducted position and floppy. So if bilateral vocal cord are paralyzed and bilateral there is an SLN palsy, what will happen? Both the vocal cords cannot come to midline. As a result, bilateral SLN palsy presents to you with aphonia. So, stridor is a feature of bilateral RLN palsy. Aphonia is a feature of bilateral SLN palsy. Okay. So, is this clear? Where do we get askew-shaped larynx? We get this in unilateral superior laryngeal nerve palsy. Okay. So this is understood. Now, what about combined palsy? If there is a unilateral combined palsy, meaning RLN plus SLN on that side is paralyzed, what will happen? The normal cord will also be in the intermediate position. Paralyzed cord will also be in the intermediate position, but it is bowing and it is floppy. Okay, so during adduction, it cannot come to midline. During abduction, it cannot go away from the midline. Again, this patients will present to you with a breathy voice. And there is going to be, they cannot increase the pitch of the voice. But if it is a bilateral combined palsy, both the vocal cords will be in your intermediate position. So bilateral cords are going to be in intermediate position and both of them cannot come to midline. So aphonia is a feature of bilateral SLN palsy and bilateral combined palsy. Okay. So I'm hoping you know the position of the chords, you know what is the effect of voice and what is the effect on respiration in all the 6 palsies that we have discussed. So we now know that stridor is a feature of bilateral RLN palsy. Bilateral SLN palsy will present to you with aphonia. So that is why when you do a thyroid surgery near the lower pole of thyroid, it is very much possible that when you are ligating the inferior thyroid artery, you could possibly damage the recurrent laryngeal nerve, and that is why they could have stridor. Okay, so if this situation happens, you have to do a tracheostomy and then you have to open the airway to allow air to go inside, which we call it as type 2 thyroplasty. Okay, so I think this is sorted. Now let's go to the next question. Use of mitomycin C is in post-adenoidectomy bleeding, myringoplasty, subglottic stenosis, or rhinocerebral mucormycosis. Yes, that's absolutely right. So mitomycin C is an anti-proliferative drug. So whenever there is a stenosis, you have released the stenosis and now you don't want re-stenosis to occur, then you're going to give mitomycin C. Now in post-adenoidectomy in the ward, the child started to bleed. The next step in the management will be to take to OR and pack the fossa with a hemostatic agent. Take the patient to the OR, remove the clots and ligate the bleeding vessel, cautery or conservative management. So basically this is a reactionary hemorrhage, very similar to your tonsillectomy hemorrhage. So whenever there is a reactionary hemorrhage, it is usually due to dislodgement of the clot or slipping of the ligature, or if there is a bleeder that has started to bleed. So do you think only packing will help in that situation? No, it will rebleed. So what should you do? You have to remove all the clots, check what is that artery that is bleeding and ligate the bleeding vessel. So that should be your answer. During accession of the submandibular gland, the Wharton's duct was injured. What nerve is at risk? Inferior alveolar nerve, lingual nerve, hypoglossal nerve, or nerve to mylohyoid. Just give me a moment. I have to take a call. 1 second, guys. Okay, I'm sorry for that discontinuity, but I'm here. So now let's continue. So during accession of the submandibular gland, the Wharton's duct was injured. Which nerve is at risk for injury? Can you all answer? So Wharton's duct is the duct of the submandibular gland, and the duct is intimately or very closely related to the nerve which runs quite deep to it. So the nerve that is at risk is going to be your lingual nerve. Okay, so the nerve at risk is going to be your lingual nerve. Fine. A mother got her child with symptoms of dysphagia. X-ray is given below. What is the diagnosis? So you see there is a foreign body here, but you're not sure it is in the airway or the soft or in the esophagus. So you should just follow this. If it is in the prevertebral anterior column, which is made up of your airway, it is going to be in the larynx or the trachea. But if it is in the soft tissue shadow, which is behind, then it indicates to you that it is in the digestive tract, and typically it indicates to you an upper esophageal foreign body, because that's the site where the foreign body will get lodged or impacted, and that is the site of impaction. Okay. Following skull-based trauma, the physician was checking on the image shown below. What nerve is being checked? Again, this is a 2024 question. They have asked this question to understand whether you know something about gag reflex. So they're trying to take a spatula and irritate or stimulate the palate, and they're asking to you, do you know about gag reflex? So for gag reflex, there is an afferent nerve and there is going to be an efferent nerve. So what is an afferent nerve in the gag reflex? It is going to be the ninth nerve that is going to carry the sensations, and then from there you have the efferent coming via the vagus nerve. So whenever you want to check the vagus nerve and the gag reflex, you are going to do this test. And why do we do this in a patient with skull based trauma? Because at the base of the skull we have got numerous foramina from where the cranial nerves will exit. So you want to check individually, are the cranial nerves functional or not, and to understand if the ninth nerve, 10th nerve are functional or not, you will assess the gag reflex, which is done by doing this test. Yes. A patient has recurrent episodes of vertigo, fluctuating hearing loss, and tinnitus with sensation of oral fullness. This is very characteristic feature. Episodic vertigo, SNHL, tinnitus, oral fullness, VST, which we call it as. This is a classic triad seen in which condition? This is seen in Meniere's disease. So in BPPV, classically we'll see that the vertigo lasts for a few seconds to a few minutes. It is not associated with hearing loss or tinnitus. In Meniere's disease, we see that the vertigo lasts for a few minutes to a few hours. it is associated with fluctuating, not a constant, fluctuating low frequency sensory neural hearing loss with double hearing, which we call it as diploacusis. And they will have tinnitus. What kind of tinnitus? There will be a roaring kind of tinnitus. Okay, vestibular neuritis. There is a long episode of vertigo lasting for days to weeks, and there is no hearing loss. Acoustic neuroma typically will present to you more with balance issues and unilateral SNHL. So the classic history that is telling to you fluctuating hearing loss, tinnitus, episodic vertigo is Meniere's disease. Now, what is the investigation of choice to diagnose this Meniere's disease? Can anyone tell me what is the investigation of choice? It's going to be electrocochleography. On electrocochleography, if you see SP by AP more than 30%, very good, it is going to be Meniere's disease. Okay, then it is going to be Meniere's disease. What will be the treatment for Meniere's disease? Intratympanic steroids followed by intratympanic gentamicin if intratympanic steroid fails, and intratympanic gentamicin fails, then you will go for surgery. You can give labyrinthine suppressants like promethazine, etc. in the early stages just to suppress the vertigo, but steroid forms the mainstay of treatment. You can put microwave, microcatheter, you can put drug eliciting substances into your middle ear, but the goal should be to give steroids into your middle ear so that the patient has relief from symptoms. Okay. Next one. A child presents to you with fever, sore throat, tonsillar exudate, and you are seeing that there is going to be lymphadenopathy and there is no cough. Which scoring system is used for likelihood of streptococcal tonsillitis? Is it the center criteria, Wells score, Ranson criteria, or Apache 2 scores? Yes, so the answer for this question is going to be your center score. So the center criteria or center score is based upon four things: presence or absence of fever, and any fever more than 100.5 degrees Fahrenheit is considered as significant and we will give 1 point for it. If there is presence of exudate, tonsillar swelling with whitish exudate, then you'll give 1 point for it. If there is presence of lymph nodes, then again you'll give 1 point for it. And if there is cough, then again you're going to give 1 point for it. So if the score is 0 to 1, then there is low probability that it is a streptococcal infection. But if it is 2 to 3, then there is a moderate risk, and 4 points indicate to you a high risk of streptococcal infection. So for each of this you give 1 points and you see that how much is the score, and this criteria is called as centers criteria, which will tell us the probability that the tonsillitis is streptococcal tonsillitis. So I think this has come as a 2023 question and I'm hoping that all of you knew this prior. Yes. A patient with severe tonsillitis develops trismus and a hot potato voice. Very importantly, you are seeing something called as a hot potato voice, and there is a unilateral tonsillar bulge with uvular deviation. What is the probable diagnosis? So whenever we see unilateral bulge of tonsil, there are two differential diagnoses that we definitely should consider. What are the two differential diagnoses? The first differential diagnosis will be a quinsy or a peritonsillar abscess. The second one will be parapharyngeal abscess. Which compartment parapharyngeal abscess? The prestyloid parapharyngeal abscess. In peritonsillar abscess, there will be no neck swelling, but in parapharyngeal abscess there will be neck swelling. Okay, so now they have told you hot potato voice and there is a unilateral tonsillar bulge with uvular deviation. It is suggestive to you of peritonsillar abscess. In retropharyngeal abscess, again they can be seen in children. They present to you with difficulty in swallowing, difficulty in feeding. But pharyngeal wall bulge, if you see, the pharyngeal wall bulge is on one side of the midline, is on the side of midline. Ludwig's angina is cellulitis of the submandibular space, which I have a question again. Acute epiglottitis will present to you with inspiratory stridor. And typically they will give you a position which is called as tripod position that they will give to you. Okay, they can maybe having a little bit of muffled voice, but inspiratory stridor, tripod position, and along with that dysphagia, odynophagia, drooling of saliva in a 5 to 7-year-old child following a URTI should prompt you epiglottitis. You will do an X-ray which will show to you a thumb sign. Okay, so I think we have understood about your abscesses here and your presentation of them. So let's go to the next one. Which of the following is an accepted indication for elective tracheostomy? Anticipated prolonged mechanical ventilation, asthma, uncomplicated allergic rhinitis, none of the above. Yes, Bhuvana, that's right. But if you see a child who's having acute epiglottitis and is not having stridor, you have to do a fiber optic intubation, or you have to give inhalational agents before you intubate the child. Don't intubate the child in making the child to cry, because that will further aggravate the disease. Never examine a patient with acute epiglottitis. If a patient with acute epiglottitis comes to you with the stridor, then you go for tracheostomy, not for intubation. Yes, it is prolonged mechanical ventilation. What is the meaning of prolonged mechanical ventilation? If some patient requires ventilatory support beyond 7 days, beyond 10 days, then you cannot put the endotracheal tube for a prolonged duration of time beyond 7-10 days, because then tube associated complications like subglottic stenosis, inability to ventilate the lungs, you will have to change the tube because the tube will get blocked. All of those complications will start. So to long term, if we need a mechanical ventilatory support, then we have to convert from endotracheal tube to a tracheostomy between day 7 to day 10. So day 7 to day 10, you are going to convert mechanical ventilation patient to a tracheostomy. Yes. Following thyroidectomy, a patient develops hoarse and a breathy voice. Injury to which nerve is it responsible? See, there is a breathy voice, it is hoarse. They have not told you anything about respiratory distress, dyspnea on exertion, nothing is given. See, if they give you some respiratory issue like dyspnea on exertion, then you think of unilateral RLN palsy. But if they give you stridor, then you think of bilateral RLN palsy. But they're telling to you breathy voice. Why is there breathy voice? Because one cord is able to move to the midline and away from the midline. Other cord is not able to come to the midline. As a result, during phonation, there is air leak. So this cord is coming to the midline. It is able to phonate. The opposite cord cannot come. There is a phonatory gap and air is escaping. This is what happens whenever there is an SLN palsy. Now, whenever we do a thyroidectomy, in general, left recurrent laryngeal nerve has a higher risk of palsy. So, in general, left RLN is at a higher risk of palsy as compared to other nerves. But if they ask you in thyroid surgery, then it is external laryngeal nerve at higher risk than the recurrent laryngeal nerve. And whenever the SLN is injured, you're going to have a breathy voice. And where does this happen? This happens near the upper pole of the thyroid. Okay. So I think this is also sorted. A young child presents to you with bilateral nasal polyps, recurrent chest infections, and malabsorption. Why is there recurrent chest infections? Why is there malabsorption? Is it because of allergic rhinitis, cystic fibrosis? Very, very good. Or chronic sinusitis or nasal septal deviation. Even before I could read out, all of you have answered. The answer is cystic fibrosis, because of which the patient has recurrent chest infections and there is improper drainage of the sinuses resulting in recurrent nasal polyposis. Adolescent male presents to you. See, again, this is very easy. We have done this. This has come like every year. If you see, this question comes. Male, adolescent, bleeding, progressive nasal obstruction. This is like a constant. We know the diagnosis is JNA. Okay. A elderly patient reports bilateral gradual symmetric high frequency sensory neural hearing loss and difficulty in understanding the speech in noisy environment. What is the most likely diagnosis? Yes, if you see a downsloping type of an audiogram, you should think about Presbyacusis, especially if it is an elderly patient, gradually progressive, symmetric, high frequency. These all the wordings are the buzzwords for age-related hearing loss, which we call it as presbyacusis. Otosclerosis, we have seen it will be female patient presenting to you with conductive hearing loss, and on audiometry we will see the Gerhardt's notch. In Meniere's disease, we don't see high frequency, we see low frequency hearing loss, and it is upsloping graph, not a downsloping graph. Eustachian tubal dysfunction again will cause you a conductive hearing loss. So the answer here is going to be your presbyacusis. A patient develops sudden sensory neural hearing loss. Now, this is again a very hot topic where a lot of questions are coming in the recent times. They're asking to you that there is a patient who has sudden hearing loss over the last 72 hours, means 3 days, and no identifiable cause. What is the initial management? They have asked in INI also. So, more than 30 decibel hearing loss in 3 consecutive frequencies in less than 3 days. What should we think of? We should think about sudden SNHL. So in sudden sensory neural hearing loss, it is an emergency. Why is it an emergency? Because the earlier you treat, the faster will be the recovery. The delay you treat, there might not be hearing recovery at all. So the first line of treatment will be systemic steroids. So in systemic steroids, you can give your IV steroids, you can give oral steroids, and as in salvage therapy you can add on intratympanic steroids. So the correct answer will be oral and intratympanic steroids. Antibiotics have no role because it's most commonly viral. Immediate cochlear implantation is not necessary. If there is a hearing loss that is happening because of a nerve related issue, cochlear implant will not help. The cochlear issue is there, then it will help. So this is to be done after evaluation. Is there a cochlear pathology or a retrocochlear pathology? If you observe and the time window is gone and you lose this emergency period, then the hearing may not recover at all. Etiology is most likely idiopathic. Sudden sensory neural hearing loss, we don't know the etiology. There is no identifiable cause in most patients. Post-viral can be in some. Following excessive or a loud sound, that could be there. But if there is a loud sound as the cause, then we say it is noise-induced hearing loss. Okay? Or acoustic trauma also. A midline neck swelling is seen in the young patient that moves upwards on protrusion of the tongue. What is the likely diagnosis? I think this is a constant. Every medical college will teach you this. Then in surgery rounds and ENT rounds, they'll tell you, ask the patient to swallow and see the movement of the thyroid and then movement with the protrusion of tongue. So I'm sure all of you know this. Yes, this is going to be your thyroglossal cyst. A patient with poor dental hygiene presents to you with rapidly progressive swelling. So as soon as you see the image, you should know the diagnosis of the tongue and there is an airway compromise. What is the most likely diagnosis? So even if you see the image, you can get to the answer. This is identified by a criteria which is called as Goldring's criteria. What is Goldring's criteria? It says that Ludwig's angina is cellulitis. It is not an abscess. There is presence of serosanguinous fluid. So there is serosanguinous fluid and there is no pus. Third, it is always bilateral. It will spread via tissue spaces. Normally the infection will spread via lymphatics, right? So here it is going to spread via tissue spaces and not via lymphatics. And here you will see that there is going to be the sparing of submandibular salivary gland. So the submandibular gland, although is there in the involved area, it is going to be spared. This criteria we call it as Goldring's criteria, which is there for Ludwig's angina. Now, if a patient presents to you with Ludwig's angina with stridor, what will you do? Emergency tracheostomy. And if a patient presents to you without stridor, what will you do? You are going to do an awake fiber optic intubation. Okay, so I think we have covered Ludwig's angina as well here. Let's go to the next question. This is again a constant favorite in the NEET. A patient presents to you with unilateral facial palsy ear pain and vesicles over the pinna. This is classic vesicles in the region of concha, element type of facial palsy with eighth nerve involvement. Is it Bell's palsy, Ramsay-Hunt syndrome, acute otitis externa, or masteritis? Yes, it is Ramsay-Hunt syndrome, also called as herpes zoster oticus, where the herpes zoster remains latent in the geniculate ganglion. And whenever there is a reactivation of virus, you'll see vesicles, you'll see extreme pain, seventh nerve involvement and eighth nerve involvement. You have to give antiviral steroids as the part of therapy. The prognosis here is going to be bad. So with this, I finished the last 5-year MCQs that were there in ENT. These were about 40 questions. In ENT, generally we get about 8 questions to 10 questions. 8 is an average, I would say. So in the last 5 years, the questions which were asked, and the last 25 I have given all the questions. The rest of the 4 years, the questions which were repeated, I have removed. The non-repeated questions I have added, so that you know that at one place your 5 years questions have been summarized and have been done. I try to do it quite fast because I don't want to stretch this session, go into details, make it a long one, but instead a short, crisp one where you are able to revise the concepts and important points quite quickly. I hope you guys have understood this and enjoyed this session. If there's any doubts, please feel free to ask. So Bhuvana, ideally when they ask you about herpes zoster oticus, they will give you antiviral plus steroid as a combination. They will not give you only antiviral as a standalone treatment or steroid as a standalone treatment, because both have to be given. Now let's say they give you as an individual option, then take antiviral, because without antiviral the patient will have progression of symptoms and a very bad prognosis. So new type of questions, Sayani, what we have seen in the FMG is video based questions. Again, you can expect 2-3 video based questions, and we will have on Prep Ladder a video based questions, summarized into a single place eventually, and that's going to be shown to all of you very soon. So I think that's the only thing. The concepts don't change, the questions don't change, the pattern of asking can change. Now the examiner wanted to do something with videos, he played around with the videos, he can bring you animations in the next one, he could bring you anything related to AI in the next one. So we don't know what the examiner is thinking about when they're framing the question, but what we need to really learn is how we need to attempt the questions and how our foundation should be strong, that anything given to you doesn't matter. वो तुमको they give you in a normal they cook the food and give you in a normal way, or they present to you in a master chef way, you should be able to identify that banana is a banana, whether presented to you normally or presented to you with lot of dressing and decoration over it. So we need to know the concept there. If that concept is there, everything else will come to you. Yes, long stem questions can be there. We have seen some of the years they were there, some of the years it's not there, and they could ask that. Ideally, long stem questions are a part of our questions that we see in the recent exams. So yes, you could have a lot of long stem questions, image based questions. Match the following, assertion based are usually INI, they are not seen in NEET exams. So Divyansh, RLN, SLN palsy, I will explain to you. RLN supplies your posterior cricoarytenoid muscle, and this posterior cricoarytenoid muscle is the only abductor of the vocal cord. So if RLN is paralyzed, abductor is paralyzed. If it is unilateral, means one cord can go to the midline and can go away from the midline, but the other cord cannot go because it is lying in the midline position. So when paralyzed cord is lying in the midline position, the opposite cord can go away from the midline, so they don't have any major difficulty in breathing, they have dyspnea. But if it is bilateral, where both the vocal cords will lie in midline position and bilateral abductor cannot pull the vocal cord, that is when they will present to you with stridor. Then we have got the SLN. SLN supplies your cricothyroid muscle, which is your tensor of the vocal cord and secondary adductor of the vocal cord. So if the vocal cord is normally in the intermediate position and if the adductor is paralyzed, what will happen? Now the vocal cord will go to abducted position and be floppy. So paralyzed cord is in abducted position and it is floppy. Normal cord is as it is in the intermediate position. During phonation, the normal cord can come to midline. The paralyzed cord cannot come to midline. There is an air leak. So that is why in unilateral, you will get breathy voice. You will see that there will be inability to increase the pitch or tone of the voice, that is not possible. But if the same is bilateral, where both the vocal cords cannot adduct, cannot tense, what will it result in? Aphonia. I hope you got it. I hope you got it, Divyansh. Yes, Bhuvana, most common source of bleeding following tonsillectomy is paratonsillar vein followed by tonsillar artery, and the artery of epistaxis is sphenopalatine artery. That is why we ligate it first. Risk of aspiration, whenever SLN is involved, risk of aspiration is there, and highest risk is seen in bilateral SLN palsy. And for that, what do? You do a tracheoesophageal diversion and permanent tracheostomy. So you divert. What are we diverting? We are diverting the trachea. So what we do, if there is a very high risk of aspiration, we will divert the first tracheal ring and anastomose with your esophagus. So your first ring is anastomosed with the esophagus. Rest of the trachea is brought as a permanent tracheostoma. So this we call it as tracheoesophageal diversion. So now even if saliva which is there in your mouth gets aspirated, it will go into the trachea. From there it will go into esophagus, protecting your airway. This we call it as tracheoesophageal diversion and permanent tracheostomy. Okay. So any more questions? Any more doubts? So, okay, then I will take your leave. I don't see any more questions coming my way. I hope you guys are able to revise very quickly with this session, and I will see you all after your exams. My best wishes is with all of you. Take care and bye bye.